Good morning, everyone. Today I'm going to discuss with you the physiologic and the metabolic changes in pregnancy. I'm Dr. Alaa Mosbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. And this is my blog, dralaamosbah.blogspot.com, scientific site specialized in OB-GYN. You can go there to see many articles and many pictures of my operation. Let us start. So there is many changes during pregnancy due to placental hormone and due to increased blood flow to organs. Different changes happen in all body system. So pregnancy is a very special condition and affecting all system of the body, and no worry about that because it is physiological. So what we wanted to know about these changes in the genital tract, in the breast, skin, cardiovascular changes, respiratory system changes, urinary system changes, GIT, liver and gallbladder, musculoskeletal system, nervous system, endocrine system, metabolic changes, immune system changes. So there are 13 changes, and as you see in the picture, the uterus grow up till reach the full term. Okay, of course this growing uterus do pressure symptoms on the surrounding stomach, intestine, bladder here. So this growing organ can cause many symptoms also. Placental hormone affecting different parts of the body, blood flow to the uterus, genital tract, to the organs, to the endocrinological glands, everywhere. So there is many changes. As you see in this picture, all body system have some changes. Okay, let us start with changes in the genital organs. Starting with the vulva. The vulva is hypertrophied and its color changed to be violet in color, what's called Chadwick sign, and become moist and soft. There is increased secretion and there is pulsation in the vaginal fornix. It is called Osiander sign. Also, the acidity of the vagina increased due to production of lactic acid. If we take smear from the vagina, there is increase in a small intermediate cell under the effect of hormones. This is the genital tract, external genitalia. Hypertrophy will occur, increased vascularity, increased discharge from vagina, acidic pH, Chadwick sign, which is violet discoloration of this vulva. Okay, the vagina is warm, soft, and increased in capacity. All these changes in the external genitalia. Let us go to the cervix. This is the cervix. What will happen in the cervix? Many changes will happen in the cervix. Hypertrophy and softening, edema and increased vascularity, and the glandular hypertrophy. Mucus plug in the cervical canal. under the effect of progesterone hormone. This will form thick mucus plug obstructing the canal. Also, it is protective from ascending organism, so it is protective from infection. Rearrangement of the collagen fibers in the cervix, and this is important because during labor there is effacement which help the occurrence of labor. So rearrangement of the collagen fiber make the cervix more softer, okay, and it can be taken up with the lower uterine segment during labor. So what about the uterus? As you see in this picture, the uterus grow in size, change in shape also. Many changes happen in the uterus. So let us start with the anatomical one. The position of the uterus. The uterus is pelvic organ in the first 12 weeks. After that, it becomes pelvi-abdominal. So it reaches the abdomen after 12 weeks. Usually dextroposed. The shape of the uterus changes from being globular in the first trimester to become more ovoid in the last trimester, and it is pear-shaped at the start. So from pear-shaped to globular, then ovoid at the end of the pregnancy. So we have change in the position, change in the shape, change in the size. There is some landmarks. Symphysis pubis, the uterus reached 12 weeks gestation. At the umbilicus, it is 24. At xiphisternum, it is 36. Okay, what about the consistency? The uterus becomes soft. There is increased vascularity to the uterus, increased blood flow. Weight of the uterus change from being 50 to 70 gram in non-pregnant lady to become 1000 gram at term. So the uterus enlarge in size, and the weight change from 70 gram to 1000 gram at term. The capacity also increased, as you see, from 10 milliliter to 5 liter or more at term. This is the capacity. What about the histological changes? We have 2 layers, 3 layers. Endometrium, which become decidual. This endometrium will become, during pregnancy, decidual. Myometrium, the muscle wall of the uterus, hypertrophy and hyperplasia in the 3 muscle layers of the uterus. Peritoneum covering of the uterus become hypertrophic and adherent to the upper uterine segment. However, the peritoneum is loose in lower uterine segment, and this is landmark for the site where we do cesarean section. Loose peritoneum here and fixed adherent peritoneum here. So there is difference between peritoneum covering the upper segment and lower segment. This is how the uterus locks from the start of the pregnancy, 4 weeks, 8 weeks, 12, and so on till reach the term. Okay, you can see pear-shaped uterus, then become globular, then become ovoid at the end. We are still in the uterus. What about some physiological changes. Uterine contractions can be felt early in the first trimester during PV examination, what is called Palmar sign. Also, uterine contraction during second and third trimester may happen, and this is called Braxton Hicks contractions. Is it physiological? Yes. It is sporadic. It has no effect on the cervix. It is painless. It is not frequent and the non-rhythmic one. And this Braxton Hicks contraction later on at the end of the pregnancy will be the false labor pain. Uteroplacenta blood flow increased to reach 450 to 650 milliliters per minute at term. So what about the lower uterine segment? As you see in this picture, here the lower uterine segment defined as the area between anatomical internal os and histological internal os. As you see in the picture, here this is the anatomical one, this is the histological one. So this is the isthmus, and from the isthmus the lower uterine segment will be formed and increase in size late in pregnancy till reach 10 centimeter at the end. So it is small now, but will increase in size at the end of the pregnancy, reach 10 centimeters. So it is the distance between anatomical and histological internal os. As you see in the lower one, lower right corner, this is the lower uterine segment near term. This increased in length, reaching 10 centimeters. So it starts to be formed at the 4th month, and as we said, reach 10 centimeters at full term. Why the lower uterine segment is important? It is the site for cesarean section. We do cesarean section here. It is a site of rupture in obstructed labor because it is the weakest part in the uterus. Also, when the placenta implanted in this area, in the lower uterine segment, it is called placenta previa, and it can cause antepartum hemorrhage. So why the lower uterine segment is important? Because it is the site for cesarean section. It is the weakest part which rupture in obstructed labor. Also, when the placenta implanted in this area, it is abnormal and called placenta previa, and can cause bleeding, what is called antepartum hemorrhage. So what about the pathological retraction ring? This is the lower uterine segment in normal, late in pregnancy. Okay? Suppose we have an obstruction. With obstructed labor, there is a stretch in the lower uterine segment, more increase in length. As you see, more increase, the lower uterine segment in this picture increased in length, and the ring developed between the upper segment and the lower segment. This ring, this is called pathological retraction ring, which occur with obstructed labor. So it is something pathologic, not physiologic. This is the fundal level. I prefer to remember that at symphysis pubis the uterus is 12 weeks. Then you divide the distance between the umbilicus and symphysis pubis into 3 partitions. And from the umbilicus to the sternum into 3 partitions. Then you can add 4 weeks for each landmark. So if we started at 12 weeks, the next level will be 16 weeks, the next will be 20 weeks, and the umbilicus will be 24, then 28, then 32, then 36. What about 40 weeks? We know that pregnancy is 40 weeks. With engagement of the baby, the head of the baby in the pelvis here, the fundal level descend down. So 40 weeks descend down and they may reach up to 32 weeks, or in the area between 32 and 36, according to the engagement of the head and the pelvis. Also, you can detect the gestational age clinically by measuring how many fingers above the landmarks. Suppose you have the fundal level 2 fingers above the umbilicus. We consider 1 finger by 1 week. So if we have 2 fingers above the umbilicus, we can say this is 26 weeks. If 3 fingers, we will say 27 weeks, and so on. Let us continue with the changes in the genital organs and the pelvis. Pelvic ligament undergoes softening due to hormonal effect. The effect is to make the pelvis more mobile and increase its capacity, and this is something physiological. What about the ovaries? Suppression of ovulation will happen during pregnancy. Ovaries becomes more vascular, edematous and enlarged. Corpus luteum, which maintain pregnancy in the first few weeks before development of the placenta, degenerate after 10 to 12 weeks because the placenta will carry the job of production of progesterone hormone. There is increased blood flow to the ovary. Now we will go to next change, which is breast changes. We have 13 changes. We finished now the genital organs, and now we are in breast changes. Can you see in this picture? This is the breast of non-pregnant lady, and this is the breast of pregnant lady, and this is the breast of lactating lady. Of course, there is increase in size during pregnancy, increase in vascularity, increase in pigmentation around nipple. Nipple become more prominent and sensitive. Increase in size more and more under effect of prolactin hormone during lactation period. So let us go in details. In the first month, increase size and vascularity. In second month, increase pigmentation of the nipple, become prominent, erectile, more sensitive, and the primary areola develop around the nipple. Also, there is tubercles called Montgomery tubercles, non-pigmented nodule around the primary areola. In third month, secretion of colostrum may start. At fourth month, secondary areola around the primary area, which is hyperpigmented area. So we have hyperpigmentation around the nipple, primary areola, then secondary areola in the fourth month. What about skin changes in the body? Pigmentation like linea nigra, pigmentation in midline, mainly around the umbilicus, and we will see picture about that. Chloasma gravidarum, pigmentation below eyes, around mouth and butterfly area of the face. Stria gravidarum appear around 16 weeks in lower abdomen, flanks, inner side of the thigh and the buttocks, due to rupture of the elastic fibers and the hormonal effect of pregnancy. This stria is red in color. And this color will change after delivery gradually to be silvery white, what is called stria albicans. So stria during pregnancy, stria will be reddish in color, and we can call it stria rubra. Then after delivery will change to be silvery white, and it is called stria albicans, and we will see pictures. This picture of chloasma of the pregnancy, pigmentation in the butterfly area and around the mouth. This stria gravidarum rubra, reddish in color, present in the abdomen, inner side of the thigh and the buttocks. This is the linea nigra, hyperpigmentation in the midline and around the umbilicus. Linea nigra. Of course, all ladies, don't be worried about that. This is a physiological changes and will be changed later on and fade away. Don't worry, it will regress. This is the silvery white. What I said, after the delivery it will change to stria albicans, as you see in the picture. Another skin changes, which is pruritus and plaques and the itching. As you see, this is the pruritic urticarial papules and the plaques. This one. Also, itching may be due to increased bilirubin and bile salt or cholestasis. Another skin change is sensation of heat and sweating due to increased blood flow to the skin. Another skin changes is spider nevi in 10% of cases and the Palmar erythema in 2/3 of cases. So, as regards skin changes, we have pigmentation, itching, and pruritus, papule, and the plaques, and heat and sweating, and spider nevi and Palmar erythema. This is the 4 main changes which may happen during pregnancy. So we finished till now the changes in the genital organ, then breast changes, then skin changes, and now in the 4th item, cardiovascular changes. Changes in the heart, the apex beat will be shifted upward by the growing uterus. So, it is normally in the 5th mid-clavicular line in the non-pregnant lady, but in pregnant lady, due to growing uterus, the apex may be shifted up to the 4th intercostal space and out of the mid-clavicular line. Pulse rate increased by 10 to 15 beats per minute. Splitting of the first heart sound, systolic ejection murmur, soft diastolic murmur in some cases, easily hear 3rd heart sound. The blood volume increased by 45% and reach its maximum at 32 weeks. And this is very important, of course, especially if your patient was cardiac. So there is overload on the heart because the blood volume increased. Other changes, the cardiac output gradually increasing till reaching maximum at 20 to 24 weeks. increase by 30 to 50% above the non-pregnant value, and this is very important. Maximum in left lateral position and minimal in supine position. So you prefer to ask pregnant lady to lie on her left side, so the cardiac output will be more, the blood flow to the heart is more, and the blood flow to the fetus and uterus is more. So we encourage left lateral position, especially when the uterus enlarges in second and third trimester. Arterial blood pressure decreased in late second trimester, then reached the normal level in the third trimester due to decreased peripheral vascular resistance. Supine hypotension syndrome may occur due to compression of the pregnant uterus on inferior vena cava, decreased venous return, decreased cardiac output, and decreased uterine perfusion also. As you see in the picture, this is the supine position. The gravid uterus do pressure on the inferior vena cava, decrease the venous return to the heart, so decrease cardiac output. The blood volume increased by 40% and reach maximum, as we said, 32 weeks gestational age. Plasma volume increased more than the RBCs, so there is decrease in hemoglobin and decrease in hematocrit value. Total plasma and total protein decreased by 85%. As regard effect on veins, there is liability for varicose vein and peripheral edema. That's why you will see many ladies as lower limb edema during pregnancy. Coagulation. Is pregnancy coagulable state or high risk for DVT? The answer is yes. There is increase in coagulation factor 5, 7, 9, 10, and 12. Fibrinogen also increased. ESR increased. Decrease in plasma fibrinolytic activity. Increase the risk for thromboembolism during pregnancy. This is the fifth item, which shows changes in the respiratory system. As you can see in the picture, the growing uterus will elevate the diaphragm, making some effect on the respiratory system. Also, placental hormones, estrogen and progesterone, has an effect on respiratory center in the brain. So, we can say the enlarged uterus displays diaphragm up 4 centimeters, and the respiration is mainly thoracic in pregnant lady. Decrease functional residual volume by 20% due to hyperventilation. Hyperventilation is due to respiratory center stimulation by increased estrogen and progesterone, as we said before. Arterial pH rise slightly to 7.4. Dyspnea may occur due to increased sensitivity of respiratory center to CO2, elevation of the diaphragm by the pregnant uterus. For these two reasons. The sixth item here is the changes in the urinary system. Kidneys, ureter, and the bladder. Anatomically changes. Kidney size increase, dilatation of the pelvic cell system may happen, urethral dilatation sometimes, capacity of the bladder increased, there is a relaxation of the wall of the bladder, and there is urine stasis which may precipitate infection. Physiological changes. By the 4th month, renal blood flow increase and glomerular filtration rate increase, reaching up to 50%. And of course, there is decrease in serum creatinine and urea, and the increase in creatinine clearance. Glucosuria and amino aciduria may occur due to decreased renal threshold. This is physiological. The significance of urinary changes, that urinary stasis due to relaxation of the wall of the bladder, smooth muscle of the wall, and the smooth muscle of the ureter. Urinary stasis precipitate infection. Frequency of micturition, yes, may happen. The growing uterus push on the bladder. Also, during engagement, the head push the bladder, causing frequency of micturition. Creatinine clearance test is useful for renal function during pregnancy. Let us go to GIT changes, gastrointestinal tract. We will take it from the mouth, reaching the esophagus, stomach, intestine, till reaching the anus. Let us start. There is increased salivation. Yes. Gums becomes hypertrophic and may bleed. There is morning sickness in early pregnancy. In many cases, there is craving to certain type of food and refusing others. So appetite changes is very common during pregnancy in first trimester. Heartburn. Why? Because there is relaxation of the cardiac sphincter. So regurg will happen. That's why heartburn occurs. Decreased tone and motility of intestine by the effect of the hormone, especially progesterone hormone, may cause indigestion and flatulence. And the constipation also. Hemorrhoid, yes, can happen, and the pregnancy is a risk factor for occurrence of hemorrhoid or bites due to constipation and high venous pressure. Let us go to the 8th item, which is liver and gallbladder. There is increase in alkaline phosphatase, but it is not from the liver. It is placental origin. Increase in total globulin and decrease in serum albumin. Yes. No effect on liver enzymes. Gallbladder will be hypotonic, bile sometimes thick and may predispose to stool, and sometimes cholestasis may happen. Musculoskeletal system. As you see in the picture, in the right one, you will see lordosis here, in this pregnant lady, okay, which will cause back pain. And here in this picture, you can see the pendulous abdomen with weakness of the anterior abdominal wall due to repeated many deliveries in multipara. The uterus push the anterior wall down like this. So this is called pendulous abdomen. Of course, you can notice the difference between both. Pelvic ligament relaxation, yes, under the effect of relaxin hormone. Progressive lordosis and the lordotic gait. Pendulous abdomen, as you can see in the picture. Nervous system. There is increase in incidence of carpal tunnel syndrome, and you should know that, and you should counsel the patient if this happens, because it is reversible after delivery. So don't worry about this. This picture shows the median nerve, and the carpal tunnel syndrome. The 11th item, which is the endocrine system. Endocrine system include the pituitary with all hormones produced from the pituitary, thyroid, adrenal glands. Pituitary gland increase in size and vascularity. There is increase in pituitary growth hormone, increase in prolactin, increase in beta endorphin. Posterior pituitary gland increase oxytocin secretion, especially late in pregnancy, and maybe one of the theories explaining why labor start. Adrenal gland, there is increase in serum cortisol and aldosterone, which cause sodium and water retention. What about thyroid gland? There is increase in size and activity, increase in thyroid binding globulin, increase in total serum thyroxine. Parathyroid gland, increase in its function and regulate the calcium metabolism via calcitonin and the parathyroid hormone. The 12th change, which is metabolic changes. Proteins. 1,000 gram protein are retained in the body. Increase daily intake of protein, 50% for the fetus and the placenta, and the 50% for the mother. Carbohydrate metabolism is disturbed, and elementary glucosuria may occur in early pregnancy and renal glucosuria in the middle of pregnancy. Normal pregnancy characterized by mild fasting hypoglycemia, postprandial hyperglycemia, hyperinsulinemia. Pregnancy is potentially diabetogenic, yes, due to increase in peripheral insulin resistance. Also, the pancreas, the insulinase enzyme of the placenta destruct the insulin. So there is resistance in one side, and at the same moment there is destruction of the insulin by insulinase enzyme released from the placenta. Also, there is increase in level of estrogen and the progesterone and human placental lactogen, which is hormone produced by the placenta. All these increase the blood glucose. So you can consider pregnancy is potentially diabetogenic. Weight, the average weight gain from 11 to 12 kilogram. Most of it occur in the last trimester. Rate of weight gain is 400 gram every week in second and third trimester. So the first trimester there is minimal increase in weight. So any pregnant lady shouldn't be worried about if there is no increase in weight in the first trimester, because most of the increase of weight occur in second and third trimester. Fat metabolism is disturbed. Fat is stored as a depot. Increased level of total lipid and cholesterol. LDL peak at 36 weeks gestation age, while HDL reach its peak at 25 weeks gestational age. Minerals. Increased demand for calcium and iron. That's why we should support the pregnancy starting from the 4th month by iron and the calcium, and the correction, of course, of any anemia if present or any calcium deficiency. Also, there is tendency of sodium retention due to hormones of pregnancy. Water, increased salt and water retention due to estrogen and the progesterone and also aldosterone and cortisol, which is released from adrenal glands. Let us go to the 13th and the last changes in the body system, which is the immune system. Pregnancy affecting immune system? Yes, of course. Both humoral and cellular, cell mediated, and the humoral immunity decreased. That's why pregnant lady is a very special group of people. When there is epidemic of infection of certain virus, we should do care for pregnant ladies to prevent them from catching this infection, because their immunity is lower because of pregnancy, and this is very important. Interferon is absent in pregnancy. Leukocyte count from 5,000 to 12,000 may increase during labor and puerperium. C-reactive protein is increased up to 1.5 milligram per deciliter. And this is the last one. Any changes? So we can summarize the changes, the physiological and the metabolic changes which occur in pregnancy: changes in the genital tract, breast changes, skin change, cardiovascular changes, changes in the respiratory system, changes in the urinary system, gastrointestinal tract changes, liver and gallbladder changes, musculoskeletal system changes, nervous system changes, endocrine system changes, metabolic changes, and lastly immune system changes. Let us think about this MCQ question. The following is uterine change during pregnancy. Choose the most correct answer. Tender cervical motion, hard consistency of the wall, cervix is more soft with thick mucus plug, decrease the blood flow to the uterus, uterus become abdominal organ at 8 weeks pregnancy. And this is my last slide, and thank you, and I wish I see you again in other lecture. Professor Alaa Mosbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. Scientific site dralaamosbah.blogspot.com. Thank you.